I'd like to complete the session by inviting Dr. Rami Sweis to the podium. Dr. Sweis is a consultant at the University College London, and he's the president of the Association of GI Physiologists, and works internationally and nationally, really leading esophageal manometry and intervention services. However, today I think we're really going to benefit from hearing about his pitfalls in the esophageal manometry that's taking really big leaps at the moment. So thank you very much, Dr. Sweis.
Thank you very much. Thank you to Professor Sanders and the Sheffield Committee for inviting me to speak today. I'm going to speak about pitfalls in esophageal manometry. Now, this sounds like it's a very subspecialized field. I'll try to make it as clinically relevant as possible. When high-resolution manometry first came into clinical practice around 2007, 2008, we thought this was going to solve all our problems. In fact, we felt that it was going to solve all of gastroenterology. Very soon we realized actually that this is quite complex. And we learned more, as we learned more and more and did more research, we understood that there is quite a lot more to understand and to tease out, because there's a lot of pathology that was being seen that wasn't actually disease. And now we are exactly where this graph shows. Trust me, it's complicated. In fact, we now know a lot more about pitfalls than anything. So before I go talk about the pitfalls in physiology, in manometry, let's just take a step back to talk about high-resolution manometry, what it is. Basically, a catheter, which is a long catheter which has approximately between 21 and 36 sensors, is passed from the nose down to the stomach. Each sensor has sends information to a computer about pressure at that particular point. These are re-represented by the computer so that pressure is represented as changes in color. And you can see here on the y-axis, this is distance, and on the x-axis is time, so that when one swallows, you can appreciate the segmental anatomy of the esophagus as it occurs. So the top bar, if I had a mouse, I'd be able to show you, the top bar is the pharyngeal pressure zone, the bottom bar is the lower esophageal sphincter, and in between, the diagonal is, in fact, the peristalsis as it occurs. So you can appreciate this in color, patients can appreciate it and can engage as the swallow takes place. But it's not all just pretty pictures, we also have parameters that we can use to define the likelihood of success of bolus transport. I'm not going to go into that at the moment, but this all gives us an impression about function of the esophagus. The standard is to give 5 mL of water in sequence, up to 10. And based on this, we now have the classification of motility disorders, which has gone through several iterations. This I'm going to present as the version 3.0. We're working on 4.0. By the end of this year, it should be ready. But the premise of this is that we look at pathology at the gastroesophageal junction first. If there's obstruction, we define it, and we define the cause and the intricacy behind it. If it is not obstructed, then we go into the esophageal body. The esophageal body pathology can be defined as either a major motor disorder, which is never found in health, and which can lead to symptoms and obstruction during motility. This is primarily comprised of hypercontraction, but extreme hypercontraction, spasm, or complete absence of peristalsis. So these are the major motor disorders that we try to treat as a disease in and of itself. Then we have minor motor disorders. These are the ones that you hear about with regards to ineffective esophageal motility, hypomotility, fragmented peristalsis, or where peristalsis is failed and then present, failed and present. This is minor motor disorders. These do not necessarily occur in disease. They might just be outside of the normal range and can be seen in health. So if we're going to treat those, often we treat symptoms rather than disease in itself. So what are the pitfalls in manometry when looking at this big picture? Of course, there are pitfalls in interpreting manometry, interpreting the technical understanding and, of the plot. However, there's also pitfalls in defining who should be sent for physiology and how you look at the bigger clinical picture and how to interpret in terms of clinical management. So I'm going to look at all of these points one step at a time and hopefully give you a better understanding. But of course, there's a lot more than just this. So the most important thing here is for us to listen to the patients giving their history. It's very important for us to determine what is it that's causing their symptoms. What are they complaining of? Is it dysphagia? Is it reflux? Is it regurgitation? Not uncommonly, they describe vomiting. And vomiting is in fact not an indication. In fact, it is a contraindication for physiology. If patients present with vomiting and that is their primary problem, or epigastric discomfort or whatever, things outside of the esophagus, we should not be referring these patients for physiology. On that note, even if patients don't present with vomiting, but if they have the catheter inserted and they begin to vomit and they're intolerant, not uncommonly, there is a problem with interpreting pathology. And so we can see this motility or lack of motility as a consequence of the intolerance to the catheter. And it's very important in this context not to use what we see here as the disorder. So in this context, this patient has aperistalsis. This is a major motor disorder. He has no motility at all. However, he's vomiting, he's intolerant. Thankfully, this patient tolerated after a while and acclimatized, and you can see eventually motility appeared. And so this patient has normal motility, and he's been removed from the major motor disorder bracket. So it's important when patients are not tolerating the catheter, not to define pathology, but to try and find normality, and if we cannot find it, then look for another modality. Similarly here, this patient didn't tolerate. In fact, this patient only lasted 30 seconds. But you can see when looking at this report, there's high pressure in the lower esophageal sphincter, and the measurements suggested that there was obstruction. But in fact, there wasn't obstruction. When we moved on to barium swallow, you can see very nicely that the lower esophageal sphincter is open. And this patient was just straining because they couldn't tolerate. It's important when you refer a patient for physiology to determine what is the question you're trying to answer. Is it that the patient has dysphagia? Is he or she a candidate for therapy? Does the patient have reflux or regurgitation? Are they a candidate for surgery, for example? Or are you trying to exclude pathology? What about something obscure? Is the patient belching? Do they have rumination syndrome or supragastric belching or something of the sort? Please do not refer a patient just for the sake of a test. It is not appropriate. The test takes a long time. It needs to be targeted. So you need to ask a question so that the physiologist can answer it. When patients is referred for manometry to investigate dysphagia, we need to keep in mind what is the cause of dysphagia. So patients with dysphagia can fall into one of these brackets. They can either have a structural pathology, mucosal disorder, or they can be a motility disorder, or they can be normal, sensitivity, for example. We should not be referring patients with the first two cohorts, structural pathology or mucosal pathology. These patients should have had these disorders excluded before referring for physiology. We should only be referring patients for physiology where mucosal and structural pathology has been excluded. So, in other words, all patients should have an endoscopy first and/or barium. So, here are examples of patients who had manometry in our unit before having endoscopy or physiology. In this context, or barium. In this context, this patient had obstruction at the gastroesophageal junction, quite marked obstruction. They were referred for endoscopy and they had a peptic stricture. This patient did not need manometry. Similarly here, eosinophilic esophagitis. This patient had several rings and several levels of obstruction. Again, such a condition should not be referred for manometry as a priority. Manometry has an indication, but there are certain criteria in this context. This patient, in fact, had a cancer, was referred to us because they had endoscopy some time ago and it was normal. But in fact, we saw that there was an obstruction and there was recent late weight loss. We suggested an endoscopic ultrasound scan, and in fact, there was a submucosal lesion and there was an underlying cancer. So these conditions should have been picked up prior to physiology. Here's an example of an 81-year-old patient who was referred to me when I first started in my institution. The patient we were told that she had a small diverticulum diagnosed several years ago, but her primary problem is hypercontraction and spasm-like events, and she's old and she needs to have something quick like Botox. So we did manometry, and indeed she had hypercontraction. And so you can see here there's high contractile events, even intermittent episodes of holdup. And so I brought her in for endoscopy, went down, first mid-esophagus, well, there's a bit of candida there. As I progressed, you can see this is not going to be treated with Botox. On the left, you've got a massive diverticulum. On the right is, in fact, the lower esophageal sphincter, which is obstructed by the big diverticulum. And you can see this here. So had we done endoscopy or barium swallow in advance, then we would appreciate that this is not a physiological pathology, a physiology pathology. So the other thing to be aware of is that this test can be easily done by somebody giving a patient 5 mL of water in sequence and pulling the catheter out and not looking at the patient. And that often happens. But in fact, it's very important to engage with the patient. Try and reproduce the symptoms as much as possible. Try and chase the symptom, see what's going on. Here are 2 cases, for example. In the case on the right, on the left, you've got short, sharp increases in intra-abdominal gastric pressures. And slowly, the patient starts to experience food rising, and they feel the food rise into their mouth. On the right, you've got suction and release. Suction and release. You can see this by negative pressure. If I had a mouse, I'd show you negative pressures followed by positive pressure. Negative, you can see the difference in colors in sequence, one after the other. These are small belches that are taking place. So the condition on the left is rumination syndrome. The condition on the right is supragastric belching. These could be missed if you're not looking at the patient and asking them to get engaged. On the other hand, if you are just looking at the manometry and not looking at the patient and asking them about symptoms as things occur, here's a condition that looks exactly like rumination. But in fact, it's not rumination because the patient didn't complain of any symptoms at all. The patient had cricopharyngeal dysphagia, was sent for manometry. This happened to be discovered. This was probably because they're straining. And this gives the impression of rumination. So it's important for us to really pay attention to the patients, watch their symptoms, ask them to tell you when the symptoms are occurring, and document them on the spot so that we can make sense of them. Of course, there are technical errors that can occur with any physiology study. You can have sensors that fail, as you can see on the left, and what you can do is just blank them, and then you can interpret the rest of the report with whatever sensors are left. But what about when you're not sure? For example, this case on the right. This case looks like there are 2 areas of artifact. How do you know? Is this artifact true, or is this from the manometry catheter itself? So it's very easy when you think about it. All you need to do is pull the catheter. And if the artifact moves, then it's the catheter's fault. If the artifact doesn't move, then it's intrinsic. You can also shift the patient from supine to upright or upright to supine and see if it changes. On that note, we also know that there are vascular artifacts that can take place. Sometimes this is physiological and normal. And again, the thing to do here is to shift the patient. If they're supine, sit them upright. If they're upright, lay them down. See if it changes. But if it doesn't, it's quite important for us to determine, is this pathological? There is dysphagia lusuria, which is an old term. Basically, it is dysphagia as a consequence of a vascular compression. We need to determine, is the aorta interfering? Is there cardiomyopathy? Is there some other vascular condition that's causing pressure or transmitting onto the esophagus? Manometry is all about pattern recognition. So it's very important for one to look and see and interpret and look at other reports and just familiarize with patterns. So here's an example of a report. What you can see here is something very interesting. If you look at the bottom, there's 2 mirror images at the bottom of this manometry report. This is called a butterfly effect. So the bottom and so the lower esophageal sphincter is replicated twice. And that's because the catheter has curled. And without seeing this and understanding that this is what's happened, you can misinterpret and consider this to be hiatus hernia, for example. So this is a curled catheter. Now, curling of catheter can occur in many circumstances. Here is a hiatus hernia, and the catheter has curled within the hernia. And so you can see that the pressure in the chest is different from the abdomen. So when you take a deep breath in, there should be a difference in pressure. But in this context, the pressure in the chest and the pressure in the abdomen, below the lower esophageal sphincter, is in fact the same. And that's because the catheter has curled above the diaphragm within the hernia. And that's why this is a curled catheter within the hernia. And again, it's a pattern recognition. We need to be able to see this. Here is the same thing, catheter is curling, but in achalasia. So you see pan-esophageal pressurization throughout the entire esophagus, but also extending to the very bottom of the screen. But that's because the bottom of the screen is in fact the catheter that's curled upwards into that pressurized area. So that's, again, achalasia with a curled catheter. And here is an interesting case that occurred only last week in our unit. This is a patient with curling of the catheter within a diverticulum. And you can see on the manometry the butterfly effect, which then goes away as the catheter is pulled back. And this is and this can again be misinterpreted as other forms of pathology. The catheter was pulled back and then put back down, and we bypassed the diverticulum, and we saw the rest of the esophagus. Here is a case that also we got last week. It's a patient who had achalasia, treated with myotomy many years ago. But the patient came back with symptoms of obstruction and recurrence. So the 5 ml water swallow looked like this, and there's 2 pressure bands you can see there. But when you analyze this more carefully, you can see that the pressure bands, the bottom pressure band doesn't show that there's obstruction. When you measure the degree of obstruction, it's normal. But if you measure the pressure at the topmost pressure band, there is obstruction. And so we went back and repeated the endoscopy on a specialized list to look again. And in fact, what the bottom, the lower esophageal sphincter, is nice and open. So the myotomy has worked in that area. But a few centimeters above, there is obstruction. So clearly what's happened here is that the myotomy wasn't high enough. And so you can see that this is the achalasia persisting proximal to the myotomy. So we're going to perform a per-oral endoscopic myotomy on this patient to complete the myotomy proximally. As we said in the beginning, the majority of these swallows are performed with 5 ml of water. But none of you ever have 5 ml of water at a time. You go and eat, and then you complain if there's a problem when you eat. So why don't we do the same with physiology studies? In fact, it's not done commonly, and it's important for us to do that. So here's an example of a patient who had 5 ml water swallows. And you can see that with the 5 ml water swallows, it's absent peristalsis. There's nothing happening at all. Now this patient, for all intensive purposes, has aperistalsis, a major motor disorder. So if we stop there, that is their diagnosis. No surgeon's going to operate because they're worried about aperistalsis. If this patient actually has reflux disease, the surgeon would be concerned because of aperistalsis. And so this is diagnosed as potentially scleroderma esophagus or what have you. However, if we continue, not uncommonly, you see that the esophagus wakes up. And all you need is a little bit more of a challenge. And to prove, give the patient as much of a chance as possible. So this particular case, if ever you see an absent peristalsis diagnosis, look, has a patient been given what we call is adjunctive testing? Solids. Was the patient asked to eat? If they haven't, please send the patient back and tell them, please, can you repeat the study with a meal? You want to give the patient the best chance possible to look normal. On the other hand, here are cases where this is the case of a patient who had absolutely bog standard normal physiology with 5 ml water swallows. But the patient was complaining of hold-up and dysphagia. When you give solids, suddenly you see that there's an obstruction. And in fact, we asked the patient to go back for endoscopy and biopsies, and we found that this patient had eosinophilic esophagitis. They hadn't taken biopsies at the index endoscopy. Similarly here, the patient was complaining of chest pain, but the 5 ml water swallow was entirely normal. With solids, suddenly you see segmental simultaneous contractions. And so this patient indeed does have spasms and was sent off for therapy. So it's very important for us to try and chase the symptom, not just stop because the protocol ended. Here is an example of a patient with complete aperistalsis. Nothing was happening in the esophagus, and there's no obstruction with the small volume water swallows. Then we gave them a large volume of water to drink, and there you go, there's the obstruction. This is because the patient had a big baggy esophagus, and you needed more than just 5 ml of water to prove the obstruction. This patient has achalasia. We've published this just last year, looking at a cohort of patients with aperistalsis but no obstruction on small volume water swallows. 80% of them had obstruction defined by giving just a glass of water to drink freely. And you can see that the obstruction suddenly appears. And these patients had achalasia, went on and had therapy, and the results are exactly as good as standard achalasics. And this study was published in 2017, looking at 750 patients who had 5 ml water swallows and solid swallows. When you gave solid swallows, then the likelihood of a major motor disorder was more than doubled compared to 5 ml water swallows. And in 70% of them, symptoms were reproduced. So it's very important to try and chase the symptom and try and identify the pathology as much as you can. My final point here is relying only on high-resolution manometry. Remember, this is only one modality. So if you are, it's good to exclude pathology with manometry by showing that something's normal. But if you are trying to consider doing invasive therapy, such as a myotomy, for example, or something surgical, we really need multi-layer testing. We need to try and prove pathology with more than one at more than one level, and not rely on just one test. And that applies to all forms of medicine. So manometry alone shouldn't be the only test. So there are lots of other ways of doing this. The most available to us all is the barium swallow. And we're not just talking about standard barium swallow. The timed barium swallow is very important. And we've proven again and again, lots of studies have proven that this is a useful objective measure of disease, of obstruction, of whatever. By providing 150 mils of barium, 200 mils of barium in one go, and then measuring at 1 minute, 2 minutes, and 5 minutes, and defining the length and the height and the width of the retained column of barium. You and I should all not be retaining any barium within 1 minute. So it's important to determine if there is a barium height at 5 minutes, that's abnormal. And after therapy, we should then repeat the test to prove that it's responded. Another tool that is very nice to use, but is expensive, is endoflip, which can measure both distensibility and compliance within the esophagus and lower esophageal sphincter, especially if we're trying to define subtle obstruction that is not mucosal or macroscopically visible. And it is very useful, very nice tool, but it's expensive. It's not used widely in clinical practice in this country. So in summary, ladies and gentlemen, when referring for physiology, we need to interpret what is the indication. Is this test appropriate? If the patient has vomiting as a primary disorder, do not refer. If the patient has epigastric symptoms, do not refer. The patient should have symptoms that are esophageal, dysphagia, chest pain, regurgitation, etc. If the patient is intolerant to the catheter, please consider another modality. Try and don't provide a major motor disorder diagnosis based on a patient who was not tolerating a catheter. If you find something like obstruction or spasm or aperistalsis and the patient is retching all over the place, that doesn't necessarily mean that's the problem. And we've seen lots of patients who've gone off and had myotomies and all sorts based on such a test. And so, of course, they don't respond well. Please only do physiology studies where recent endoscopy and or barium has been done by someone who knows what they're doing. Don't rely on a test 5 years ago. Don't rely on a test from who knows where. If you need to repeat it, because it's important for us not to overinterpret or misinterpret what's happening physiologically if the patient has a macroscopic, a structural pathology that has been missed. And if there's an artifact, do something like move the catheter, shift the patient. Try and determine, is this true artifact from the catheter or is there something that's important that you're missing in the esophagus itself? And high-resolution manometry is complex. It requires pattern recognition. Those of you who do physiology, find a mentor, ask questions. We're a small community. There's nothing wrong with sending an email to your local friendly physiologist and asking, what do you think of this? Do you think this is a good idea? Most folk will be more than happy to answer. Be engaged with the patient. Please try and follow and chase the symptom. Don't just do 10 water swallows and pull the catheter out. That's bad medicine. We need to ask the patient, what's the problem? Is the problem dysphagia? 5 ml water swallows isn't working? Okay, let's do some free drinking. Let's do some solid swallows. Let's move you from supine to upright to supine, what have you. Try and give the patient the best chance possible to find the problem. And don't just stick to 5 ml water swallows. Try and go beyond that. Ask the patient to bring a sandwich with them. Have a bowl of rice. We have all our patients, for all presenting complaints, all have 5 ml water swallows, free drinking of 200 mils, and then a bowl of rice as a routine. And then on top of that, sometimes we ask them to bring in a meal. And do not rely only on high-resolution manometry if you're thinking about invasive testing. This is one of the results that you should look at, not the only result. Thank you very much, ladies and gentlemen. I'm happy to answer questions. Just one more thing. Just to plug our meeting, which is in February, there's a Upper GI Symposium at University College London, which is going to be virtual, live. If you'd like to register, here's the information. I'm happy to receive emails as well if you want to contact me about it. Thank you very much.
Well, we have a number of questions, Rami. First is just clarification of the food that you give to people, the nature of the food. You mentioned the higher volume water and then rice, and then a sandwich?
No, so in our unit, and this is probably not practical everywhere. In our unit, everyone gets 5 mils of water, times 10, then a cup of water to drink in one go through a straw, 200 mils, and then a bowl of rice, Uncle Ben's. You just put it in the microwave earlier so it's not hot, and they just eat the whole thing, and they've got 10 minutes to do it. And sometimes we observe them after. If you're looking at postprandial, we keep them there and we watch what happens afterwards. If their symptoms aren't reproduced with that rice, then either if they're tired by then, we bring them back and do it again and ask them to bring the culprit food. So if it's a chapati that does it, then they bring the chapati. If it's if it's tikka, they bring a tikka. Whatever. The food that causes their symptoms. We've had people come with McDonald's sandwiches and they just reproduce. But we try to replicate the problem, not do an artificial test to explain the problem that they're complaining about at home.
That's useful to know, thank you. And your dysphagia algorithm, I suspect that means presumably endoscopy and esophageal biopsies.
I think,
always?
Yeah, so routinely, everyone who comes in for with dysphagia has an endoscopy. That's a routine, that's a standard. And the endoscopy should, if there's nothing macroscopic that we can explain, such as a peptic stricture or whatever, then we take biopsies. 2 by 2 by 2, distal mid-proximal, to exclude eosinophilic esophagitis. And we determine, is there any explanation to what's happening. Sometimes what's important is just sitting there with the endoscope and just observing, seeing what happens for a few minutes. Routinely, what I do on top of that is I do a barium swallow. So I do endoscopy to look at mucosa, I do a barium swallow to look at structure, and then I do the manometry, if everything is normal.
Lovely.
And so the manometry is the end stage after all structural and mucosal pathology has been excluded, if the patient comes to me first, but that's not always the way it happens.